Okay, so the recording is started. Welcome to today's COVID Echo. My name is Brian Hendricks. I'm the Quality Improvement Data Analyst at USET. Today we have some great presenters. We have Imani Ransby, who's going to give an overview of the Nashville area. And we also have Dr. Brown, who is going to speak on the pediatric and Novavax vaccine updates and traveling the road from pandemic to endemic. Is it too soon? First, I do want to go over some housekeeping Zoom participation tips. We are building a community. Please introduce yourself in the chat and select everyone, and let your fellow participants know your name, tribal affiliation, and job title and organization. We suggest that you turn off your cell phone and enjoy the hour we developed to support and honor you. And CEUs for medical and nursing are available for this session. With that being said, I'm going to share my screen to go over some disclosures. This activity is jointly provided by Cardia Services and United South and Eastern Tribes. Cardia Services is approved as the provider of continuing nursing professional development by Montana Nurses Association. An accredited approver and distinction by the American Nurses Credentialing Centers Commission of Accreditation. Yeah, so that's the disclosure for the activity. Next, we have completing the activity. Upon successful completion of this activity, 1 contact hour will be awarded. Successful completion of this continuing education activity includes the following: attending the entire CE activity, completing the online evaluation, and submitting an online CE request. Your certificate will be sent via email, and if you have any questions, contact Kayla, and there's her email address. And there are no disclosures to report, correct, Dr. Brown? Okay. There are no financial disclosures to report. With that being said, I don't think I have anything else, so I will turn it over to, let me stop my screen. Turn it over to Imani to give her updates.
Thanks, Brian. Let me share my screen. Okay, everyone should be able to see that now. So greetings, everyone, and happy Friday. Thanks for joining us for our February COVID-19 Echo session. As mentioned, today I will be providing some COVID-19 epidemiology updates, focusing specifically on the service area or USET region. And so the next several slides that I have will showcase some of the data that's currently included in our COVID-19 USET area aggregate reports. As a reminder, we do send these surveillance reports out on a weekly basis every Wednesday, and we distribute them to representatives of tribal nations, including tribal leadership and health directors, as well as our USET staff. Alongside the USET report, tribal nations also receive a tribe-specific report, which lets you look more closely at COVID-19 in and around your community. And so you should have received your latest COVID-19 surveillance reports this past Wednesday, the 9th. If you are not familiar, these reports primarily focus on data related to COVID-19 cases and vaccinations across local, state, and national levels. In addition, data for the USET region as a whole is also available to view. It is always our hope that you continue to find utility in these reports, and do please note that they can be modified to better meet the needs of your tribal nation as you see fit. So if you do have any questions, concerns, or requests to modify the reports, please feel free to reach out to the USET Tribal Epidemiology Center, and we would be happy to assist. So on the current slide we are looking at here, we have COVID-19 testing data specific to the USET region or Nashville area. the number of new positive test results, the cumulative total of positive test results, and a 7-day positivity rate or percent positivity. And this is for the past report week of February 1st to February 8th, 2022. And as I said previously, this information was retrieved from this past Wednesday's USET report, although do note that these numbers are reflective of Tuesday data, as that is when we go to pull it, and then we send the reports out on Wednesdays. So for the current report week, the number of positive COVID-19 tests at reporting facilities in the IHS Nashville area in the last week was 433. While the cumulative total of positive COVID-19 tests was 15,953, and the 7-day positivity rate was at 23.1%. On these sessions, I generally like to refer back to some of the numbers reported at the time of our last echo and compare to where we are now in the pandemic. So when looking back to our January 14th echo and the January 12th USET report, we were at a total of 845 new positive COVID-19 test results. When comparing to this week, we are almost at half the amount of new positives. And from that, you can really tell that we have been on a decline over the past few weeks or so. As far as cumulative positive results go, we were at 12,440 the week of the 114 echo. And so we are up by a little over 3,500 cases. Lastly, referencing the percent positivity rate from mid-January, we were at 29.5%. So we did go down by about 6.4%, but do note that the 7-day percent positivity still remains high at this time. But as we start to see less and less cases, we do expect this percent to also decrease. So this graph takes a closer look at the number of new positive COVID-19 test results per week, including a 12-week retrospective timeframe to see the number of new cases across time. When looking at the line graph, you can clearly see when we started to see a noticeable uptick in cases due to Omicron around mid-December 2021, where we were at 295 cases. And it does look like we had our biggest jump during the winter holiday season and New Year's, most likely attributed to gatherings and, of course, Omicron's noted increased transmissibility compared to Delta. But as you can see, the numbers continue to rise until around mid-January, where it appears we peaked at 996 new positive test results. Since then, we have been on a pretty steady decline, at least for the last 3 weeks. And I'm sure that we all hope to stay on this trajectory, though it will likely take some time to meet or surpass some of the lowest numbers of new cases depicted on this graph, and even since the start of the pandemic. But yes, time will tell. So we shall see. All in all, we are seeing decreases in cases amongst USET member tribal nations, although we also note that the virus is still being transmitted at a high level at this time. So moving on to this next slide, the horizontal bar graphs that you see displayed show you the rate of new COVID-19 cases per 10,000 broken out by USET counties or PERCTA areas, purchase and referred care delivery areas, USET states, and then the United States. There is also a 12-week time frame available for this information, so you can look back at cases over time. Please note that the data featured on this slide is specifically obtained from CDC and state health departments and is not limited specifically to tribal citizens. Although it is not limited to tribal citizens, this information has continued to be helpful in getting insight into how the USET region is being affected by the pandemic over time, as we can look at rates locally, at the county level, by USET states, and lastly at a national level. And so we do feel that these rates can be used to guide recommendations and public health responses to COVID-19 as we navigate the pandemic. In line with what we saw on the last graph, cases are decreasing, and that is even more apparent after taking a look at this past week's data in particular. And so the USET county or PERCTA rate for the current report week of February 1st to the 8th was reported as 1.56 cases per 10,000, while the USET states rate was at 28.59 cases per 10,000, and then the United States rate at 53.91 cases per 10,000. So cases are definitely decreasing across the board when looking at the USET region as a whole. And again, you can really see the most recent wave that was brought on again by Omicron here, as shown by the curves at each level. And although the rates have been going down, there have been some fluctuations in the USET county rate specifically that I want to make note of. These fluctuations are most likely due to the initial miscoding of county of residence or backlogs in COVID-19 case reporting from various states. When referencing the USET PERCTA rate from this week in particular, I actually expect the rate to be a little bit higher than what we are seeing, but still low enough to be considered a decrease. I say this as one of the USET states has recently experienced some delays in processing and reporting their case data, and so this may have resulted in bringing down our overall PERCTA rate some. Although again, it was expected to be lower than the previous week. But in sum, for this week, the United States did have the largest case rate, followed by the USET state rate, and then the USET county rate. I wanted to cover this last slide on COVID-19 cases before we transition over to the vaccination data that I have available to share. I'm unsure how well everyone can really see this, but also note that this visual is included in the reports we send out as well, so you should have it available to you. So we are currently looking at 14 different graphs that show the state rates over time in all USET states and each individual USET state. We initially created these graphs as a request from a tribal nation, but have found them to be continue to be useful. So just a few things to point out with this slide. You'll note that Florida is a flat line. That is primarily due to not having the data needed for us to report on. They are reporting weekly and we pull our data on Tuesdays, so we simply do not have the information needed. Secondly, you see that there was a small increase in cases noted for Mississippi as of this week, and that may very well be likely due to backlogs in COVID-19 case surveillance reporting. And then lastly, I mentioned that one of the USET states has recently had some processing and reporting delays, and that was with South Carolina, where you see its state rate has dipped down all the way near zero here. So moving on to the last several slides that I have, we will now take a look at COVID-19 vaccinations in the USET region. We have been giving out COVID-19 vaccinations in the US for over a year now. And so with that time, we have been able to gain more of an understanding about how their implementation has had an effect thus far. We know that the COVID-19 vaccine has been successful in alleviating the severity of illness brought on by SARS-CoV-2, and also that data suggests that those unvaccinated are possibly more likely to be hospitalized than those vaccinated. So gradual progress still continues to be made with getting people vaccinated in the US, and the bar graph on this slide really showcases that progress from a week-to-week standpoint. So currently you are looking at the percentage of population fully vaccinated by reporting facilities in the Nashville area, the United States, and the Indian Health Service. The bar for reporting facilities in the Nashville area is based off of vaccine data sent over from IHS for a total of 17 sites conducting vaccinations, while the percentages from the other two bars are from CDC's COVID-19 data tracker. So for the recent report week, the percentage of population fully vaccinated for the USET region was 52.4%, while the United States was at 64.2%, and then the Indian Health Service at 40.6%. Also, please do note that we expect the actual percentage for the Nashville area to be higher, as we do not have data from all of our membership. So that is something to keep in mind. This next graph also showcases data on the percentages of population fully vaccinated. Sorry, I think I cut out there. So sorry, as I mentioned, this next graph also showcases data on the percentage of population fully vaccinated, but instead now we have it by all USET states, the United States, and reporting facilities in the IHS Nashville area. This graph allows you to see the percent increase that has occurred from week to week as well, like we saw on the other graph. So looking more closely at the percentages for the individual USET states, we do see that the percentages for this week range between 49.7% and 81.2%, with 0.2 to 0.4% increases seen from the previous week for all states, aside from Rhode Island, which had a 2.1% increase from the previous week. Though vaccinations have slowed down since the rollout, there may be more of an increase in the coming weeks, maybe with pediatric vaccinations pending. So we shall see. So this additional COVID-19 vaccination doses and booster doses have been underway for some time now. So we did update the report to include that data, similar to the last graph, broken out by all USET states, the United States, and reporting facilities in the IHS Nashville area. We have displayed the percentage of population fully vaccinated that have received another dose of COVID-19 vaccine. And this does include booster and additional doses. So again, looking at the percentages for the individual USET states, we see that they range between 15.2% and 60.4%, with 0.4 to 10.7% increases seen from the previous week for all states. As of yesterday, 50.2% people in the United States were still eligible for a booster dose. So just a friendly reminder to get vaccinated and boosted if you have not, and to encourage others to do so. As we know, vaccinations are not 100%. So at this time, it is still important to continue to follow prevention measures such as masking, physical distancing, and washing your hands frequently. And so then I quickly wanted to go over this last slide, which also covers COVID-19 vaccination data. This bar graph gives you the percentage of delivered COVID-19 vaccination doses that have been administered, and the information is broken out by the United States, USET states combined, and individual USET states. In sum, these percentages tell us for the current report week, a great job was done in getting COVID-19 vaccine delivered to states, administered to the public. So these percentages have remained relatively the same with little fluctuation since we've included this information in the reports. And as you can also see that the USET states percentage is close to the United States percentage, so that is also good. Before I close, I wanted to again mention that, yes, we are declining in COVID-19 cases as a whole, but the virus is still currently circulating at a high level. In recent times, there has been more of an emphasis on at-home testing, and the USET Tech is in agreement with this, as we feel that testing prior to meeting up or gathering with others can also help slow down transmission. That being said, as we come up to another popular time for gathering, the Super Bowl and Valentine's Day weekend, I do think it's still important to consider these types of COVID-19 prevention measures in addition to other practices that have been proven to lessen the spread of the virus. So if you can test before meeting with others, then definitely do so. As always, please feel free to reach out to our USET Tech team if you have any questions or concerns related to COVID-19 or any other public health concerns outside of that. We are happy to assist with any technical assistance or questions that you might have. And our email address is usetepi@usetinc.org if you would like to get in contact with us. I will take questions now, and if there are not any, then I will pass it along to my colleague, Dr. Brown.
Great presentation, Amani. Thank you. Do we have any questions for Amani at this point? Hearing none, we can move on to Dr. Brown. Talo, if you'll bring up his presentation and he can get started. So over to you, Dr. Brown.
Thank you, Brian, and thank you, Amani, for a once again giving us a great presentation on how we're doing regionally with this pandemic. So the title of today's talk is Traveling the Road from Pandemic to Endemic. Is it too soon? So there's a question at the end of that. And wish I could take credit for this clever title, but it's actually my colleague and supervisor, Christy Duke, who came up with this. And I thought it was too good a title to pass up. So first slide, please. I am going to talk about pandemic, endemic, what that all means, but I'm also sort of a vaccine hobbyist. That I can talk about vaccines all day, and it's hard for me to pass up any opportunity. So I have a couple of news items on vaccines. I'm also going to talk about an interesting article that came out just about 2 weeks ago, and I'll just speak briefly about that. And then most of today's talk will be about where we are on the pandemic to endemic timeline or road or whatever else you want to call it. But I will remind everybody, we've just passed another milestone. We're now past 700 days of the official start of the pandemic, which was on March 11th, 2020. So in just 1 month from today, we will hit the 2-year mark. Who would have thought it? Next slide. So just some news. This has really been, if you've been listening or watching the news lately, there's been quite a bit about the upcoming emergency use authorization request by the Pfizer-BioNTech people to give their vaccine to really little kids, starting at 6 months of age through 5 years. They already have an emergency use authorization for ages 5 through 15, and they've got full approval for ages 16 and up. Now, next Tuesday, the FDA's Vaccine and Related Biological Products Advisory Committee has a meeting scheduled to review this application. I expect that meeting to have a few fireworks. The main one being they've submitted the data for a 2-shot primary series for this age group. Now, the dose that they used was a very small dose. It was 1/10 of the adult dose, only 3 micrograms as opposed to 30 micrograms. And at least, I haven't seen the actual data. I don't think anybody has. I checked just a couple of hours ago. The FDA website still has not put up the materials for the meeting. It should come out today or Monday at the latest. But the news is that for children 6 months up to about 2 years, they did show, good results. But for the kids from their second birthday up to age 5, the vaccine didn't do what they were hoping it would do. But they're still asking for an emergency use authorization. Now, what they are doing is studying a 3rd dose to see if that boosts those kids up to where they need to be. And this was not really an efficacy study because that takes something on the order of 20, 30,000 participants. They just had a small number, like on the order of 2,000 or 3,000 kids in this study. And they do what's called immunobridging. They give the kids vaccine, and then they draw their blood and they check for antibody levels. And they compare that to the older age groups that they have data for. And the assumption is if you get these high antibody levels, then you should have good immunity. So we'll see what happens. It's going to be an interesting meeting, and I would say stay tuned for further developments. Our next ECHO in a month, we should have a lot of news about this. Next slide. So this is a big, a lot of information on this slide. The only thing that I want to have you really notice about this if the vaccine is approved for 6 months through 4 years, then there will be 4 different formulations of the vaccine. They each have different colored labels and tops. Purple is for 12 and older. Gray is also for 12 and older, but it's a different formulation that doesn't require any dilution. And then there's an orange cap that's for the 5 to 11-year-old age group. And then the one for the little bitty kids will be maroon colored. I got this slide courtesy of my colleague, Emily Baer. And this isn't for public consumption yet because this hasn't been approved. So, but just wanted to give everybody a heads up that you really need to pay attention to the color of the vial, the color of the cap. Don't give the adult formulation to kids and don't give the kids formulation to adults. So next slide, please. There'll be more about this at a later date. So in other vaccine news, the Moderna vaccine received full FDA approval for ages 18 and older. FDA gave that on the 31st of January. CDC followed a few days later on the 4th of February. So now we have 2 vaccines that have full approval for adults, the Pfizer-BioNTech and the Moderna. What does this mean? It just means that they've done all the extra paperwork and time to show that the vaccine is fully effective and safe. So for those people who say, well, that vaccine's not approved, I don't want to take it, we can now say, no, it is fully approved, at least the 2 mRNA vaccines, Moderna and Pfizer-BioNTech. Now, for those of you who have listened to other presentations I've done, you know, I keep bringing up this Novavax vaccine. I don't have any stock in their company. I don't necessarily have, you know, it's not necessarily my favorite vaccine. It's just that this vaccine uses a different technology, a technology that's been around since the 1980s. It's the same technology that produces the hepatitis B vaccine, which has been around for a long time. So for some people who are reluctant to get a vaccine that uses a new technology like the mRNA or the viral vectored vaccines, that's the Johnson & Johnson vaccine, they might be more willing to accept a vaccine that's made with an older tried and true technology. Now, we don't necessarily know that Novavax is going to be any safer than the vaccines we currently have. We do know about its effectiveness. Their original trial showed very high effectiveness on the order of 96% against the original strain. Now, I'm going to underline that, against the original strain. The original strain's not around anymore. So now we're dealing with Omicron. Now, Novavax did just announce yesterday that the preliminary results of their trial in adolescents, I mean, they've been conducting this clinical trial for ages 12 to 17. They don't even have an EUA for anybody yet, but, you know, good for them. They've been pressing ahead with clinical trials. They showed an 82% efficacy against COVID. Now, this trial took place between May and September of this past year, so they were dealing mainly with the Delta strain. So while that 82% efficacy, you know, that doesn't sound as good as the mRNA vaccines, actually it is, because the mRNA vaccines are about that efficacious against Delta. Now, unfortunately, we're dealing with Omicron, and as you know, our current vaccines are not as good against Omicron as they were against previous strains. So we'll see if Novavax does well against Omicron. Some preliminary data from just lab type tests, not human trials, shows that it probably is pretty good, but it's not as good as it was against the original strain or against Delta. Now, the Novavax vaccine is already being used in many countries, including the United Kingdom, the European Union, Australia, and quite a few others. They have applied for an EUA, and my guess is that sometime in the middle of March, the FDA will meet on this. So, we'll probably have a pretty quick approval, barring any unforeseen problems with it. So, by the end of March, we'll probably have a fourth vaccine that we can use in the US. You can say, so what? But like I said, there may be some people who have been vaccine hesitant who are willing to accept this vaccine over the newer ones, the newer technologies, I should say. The other good news is if Novavax can ever get their production ramped up, and that has been a real struggle for them, if they can ever get their production ramped up, this vaccine does not require freezer temperatures. It's pretty stable at room temperature for a long time. So this will be a great vaccine for less developed countries that don't have constant refrigeration or freezers, and don't have the high-tech super cold freezers. So it will be another weapon in the worldwide fight against COVID-19. Next slide, please. So this is that article I wanted to talk about that just came out a couple of weeks ago, the journal Science Immunology. This article answered a question that, as far as I know, hadn't really been answered up until now. And the question is actually not, do I need to get vaccinated? The question is, does getting COVID after I've been vaccinated give me better immunity? And that was actually the question that this article answered. Is my sound okay, Brian? Okay.
Yeah, it went out for a second, but it's back.
Yeah, I thought it did. So what this article, basically, I'll summarize it quickly. It was a case control study. There were 3 different groups. So one group was vaccinated, and they had not been infected either before they were vaccinated or after they were vaccinated. So no, vaccinated, but no evidence of infection ever during the study. Then there was a group that had COVID-19 and got vaccinated after. And then there was a third group that hadn't had COVID-19. They got vaccinated and then later got a breakthrough infection. Now, it was already well known that if you had had COVID-19 and you got vaccinated, your immunity level was higher than people who had been vaccinated but had never had COVID-19. What this article showed was that if you got vaccinated and later had a breakthrough infection, probably due to Delta, because that was the period of time that this study was done, you got higher immunity than just with vaccination alone. So does that mean that you should, purposefully get COVID? No. Does it mean you should wait until you get COVID and then get vaccinated? No, because we know that vaccination, even if you don't have that extra boost from having an infection too, it's still protective against severe disease. In fact, some of the latest data says that vaccinated people are 68 times less likely to die from COVID than those who are vaccinated. To say that the reverse way, if you haven't been vaccinated, you're 68 times more likely to die from COVID than if you have been vaccinated. But what the important thing about this paper, and if you want to read it for yourself, the references there, the bottom line is if you get a breakthrough infection, which most likely you're not going to get thrown in the hospital or die from it, the silver lining is that you will get even better immunity if you had been previously vaccinated and got a breakthrough. Next slide, please. Now I'm going to shift gears and talk about, there's been a word that I've heard in the news a lot lately, and that is endemic. So I think there's a lot of misunderstanding out there about what endemic means. It doesn't mean that the disease has gone completely away. It doesn't mean that it's become less dangerous. So just to go over a few terms, an epidemic is when you have an outbreak of a disease. It affects a large number of people within a community or a population or a region. A pandemic is an epidemic that spreads over multiple countries or continents or the whole world. That's what we're in right now, a pandemic. Now, endemic isn't, that the word is not just about disease, but it's anything that belongs to a particular population or a region. For instance, ice is endemic to Antarctica. You know, ice is always around in Antarctica. But as it applies to disease, it's a disease that is in a population or a region all the time. But endemic implies that there's a more or less constant number of cases. So, you know, you could have an endemic disease that still was causing a lot of cases. It's just not causing big peaks and valleys of cases. Next slide, please. So where are we on the pandemic highway? I got this graph. This is from our World in Data, and this is sort of the course of the pandemic worldwide. You can see that there were a couple of waves before the big wave last December. And worldwide, there was a big wave in the spring of last year. This was mainly due to the huge epidemic that they had in India during that time period. Then that next bump that you see is the Delta outbreak in Europe and North America and a lot of other countries. But look at that gigantic peak that we have just experienced worldwide. That's Omicron. Omicron has completely dwarfed the other peaks during the pandemic. On the next slide, I'm going to show you a few different countries. So China was the first country to experience COVID, as far as we know. And you see they had a big peak way early. And since then, they've been relatively very few cases. Now, some may question, you know, can we trust the data from China? I don't know the answer to that, but, you know, it would appear that China, after they had their first big outbreak, which was actually pretty small compared to what we've experienced worldwide since, China has kept things under pretty good control. But they've done that through very draconian measures. You know, they will go into lockdown if there's just a couple of cases in a city. The whole city's put on lockdown. They have very strict rules about masking and social distancing. So China, by imposing some very stringent public health measures, has managed to keep the numbers down. It'd be very difficult, I think, to replicate that in a society that is as free and diverse as ours is. Next slide. So Australia, which is an island country, they had a lot of success at keeping it out until Omicron. And Australia is fairly highly vaccinated, but again, our vaccines were developed against the original strain and not for Omicron. So Australia has recently seen their highest number of cases by many orders of magnitude. But you can see that they are definitely on the decline at this point. Next slide. South Africa has had a really interesting pattern throughout. They've had 4 very distinct waves. Their waves are have a lot more peak to them with very low levels in between. And I haven't really seen this in most countries, and I'll show you that in just a minute. But that last peak that you see is Omicron. And interestingly enough, even though it was the highest, it wasn't that much higher than their Delta wave was, which occurred during the summer. And as you can also see, they had a very sharp upswing, very sharp downswing, but they've leveled off at a higher level than most of their other three waves. So we're kind of keeping our eye on this, or I am, just to see where they go with it, because they're about a month ahead of us on the Omicron wave. Next slide. Now here's the United States. So, you know, we had an initial wave in March and April of 2020. We had another wave that summer. It's almost, you almost can't see these because compared to Omicron, they weren't that big. Then we had this huge wave back last winter. We all remember it seemed like it went on forever. Then vaccines came out, we had a drop, and we dropped down to very, very low levels back in May and June of last year. And I had high hopes that the pandemic was over. But then came Delta, we had another big wave, but look at Omicron. Omicron just dwarfs all the other waves we've had. But the good news is, look at where we are with Omicron. Cases are really dropping rapidly at this point, and we are still on a steep decline. We haven't leveled out yet. It's going to be interesting to see how that goes. And I'll say a little bit more about that towards the end of the talk, and I hope we have time for discussion. Next slide. This is the CDC epi curve. An epi curve is just the cases over time, and you can see that sort of dark red line is the average, the 7-day average. So, you know, again, we see the first two little waves, then the big wave last winter, then the Delta wave that happened in late summer and fall, and then Omicron, which has been huge. But on the next slide, I'm going to show you the death rate superimposed on this curve. So this is interesting because you see that first wave, the death rate was totally out of proportion. It was a pretty big death rate. Now, why was that? I think there were several reasons. For one, there were a lot of old people, a lot of nursing homes that had an outbreak. And as we know, the elderly are much more likely to die. The other thing was we had no idea how to treat it. It was before we knew that dexamethasone was very effective at keeping people from dying. It was before we had remdesivir. Whether or not it really does much good once people are in the hospital is open to question, but we were using a lot of ventilators rather than high flow oxygen. We've since found that high flow oxygen sometimes is better than the ventilator. So the biggest death rate, the biggest peak there occurred last winter. We had another pretty big peak with Delta, but I think by Delta, we had learned how to treat it better. Also, we had a lot of vaccinated people. And as we've seen, vaccination, even if you get a breakthrough case, you're much, much less likely to die. I suspect that if we had not had vaccine, that Delta death peak would have been even higher than the winter peak that we saw last winter. Now, look at Omicron. Everybody's been saying, well, Omicron's mild disease. It's not so bad. You know, it's not deadly. Well, unfortunately, it is deadly. As you can see, I hope that we're past the peak death rate. I think probably we are. The death rate always lags a few weeks behind the cases. But, you know, more people have been dying from Omicron than were dying from Delta. And that's because we've had far, far more cases. So even a small percentage of a big number is still a big number. That's kind of the point here. So next slide. I wanted to give a little bit of a historical perspective. This was the flu epidemic back in 1918, 1919. They had 3 waves of it. There was an initial wave in the sort of summer of 1918, followed by a huge wave that winter. Then they had another wave in the spring of 1919. Now, if you, and I couldn't find a good graph that showed this, but after 1919, there was actually another wave in 1920, and all through the 20s, every winter, there was a wave of influenza, and it's pretty much been that way ever since. Influenza is a very seasonal disease, at least in the temperate zones. In the tropics, they see influenza year-round, just at kind of a low level. But in the more temperate zones, the winter is when influenza happens. So what can we learn from this? Well, I'm just going to have a few speculations here, and we can go to the next slide, which I think says, so when will COVID-19 become endemic? Well, barring some kind of unforeseen miracle, some kind of magic bullet, I'm afraid the virus is here to stay. I don't think we're ever going to see the end of COVID. It will become endemic at some point, but I don't think we're there quite yet. But as we get more immunity from vaccination and from natural disease, we'll see probably smaller waves in the future. And because it's a coronavirus, and most of the time coronaviruses are seasonal, they tend to happen more in the fall and winter. I think COVID-19 will become sort of an endemic epidemic disease. It'll always be there. We'll have cases probably all year round. We'll have more cases in the colder weather months as people, are indoors and can spread it more rapidly. But we're just going to have to learn to live with it. Are we going to continue to have to wear masks forever? I would say probably not. It may be that Omicron has infected so many people, and Omicron has outcompeted all the rest of the variants so far. Omicron may be the variant that we're stuck with for a while. That may not be such a bad thing, because Omicron does appear to be less virulent. If we end up having an Omicron-specific vaccine, it may be even less of a problem. So there's a lot still to be seen, and I don't have a good crystal ball. But I would say, it's still a little bit early to really relax our public health measures. We need to press forward for a little while longer, a few more weeks at least, until we see a real, really true low level of COVID. Next slide. So, I just wanted to end on some positive notes. Where are we 2 years into this? Well, we're better at taking care of COVID. We know a lot more about how to take care of it, better supportive care. We have some effective antivirals now, some effective monoclonal antibodies, so there's treatment. We have 3 safe and effective vaccines in the US, probably soon to have a 4th one. We have much better knowledge about the virus itself and about what works to contain it and to treat it. And now we have Omicron, a variant that's more contagious than any of the previous ones, but it's also less deadly. So maybe this will be our path to a more livable situation with COVID. That's my optimistic outlook today. So thanks a lot for your time and attention. I think that's the end of my presentation. Next slide. Yes, it is. So the turtle here, one of my favorite animals, just to remind us that, we're in it for the long haul. This is not a rabbit disease. This is a turtle disease, slow and steady. So I will entertain questions or discussion. I'd especially like to hear from people about, are you relaxing your public health measures yet? Are you doing anything to try to encourage people who are unvaccinated to get vaccinated? How are you doing with encouraging boosters? It would appear that both as a country and as a region, we're not doing great on boosters. Also, just as a country, we are 75th in the world as of yesterday in terms of vaccination rates. There are 74 countries that are ahead of us in vaccinating their population. Not a very good, not a great track record for us.
Our rates in Alabama, I know here for us specifically, we had a 47% 2 weeks ago. It's been steady in the 30s ever since. This week we have seen a downtick. So we had a call with tribal council because people are mask weary and they're tired. And but our advice, and I think they're going to stick with that, is reevaluate at the end of February, after Valentine's, President's Day weekend, all of that, and just don't go backwards. We're slowly declining, so let's keep our measures in place here. So I think I know that's what we're going to do for now. But the health department will continually mask up, until we see data that convinces us otherwise.
Hi everybody, Chief Cook here. We're keeping our measures in place also for the very same reasons that Nancy said, where our cases have been, it's all relative, but our cases have been high and are just now starting to go down. The hospital bed availability in our region was nil. People were being transferred out hundreds of miles away because there were no beds. That's beginning to ease up a little bit. Part of it was because of hospital staff becoming infected, or they lost staff because they didn't want to become vaccinated, whatever the reason was. But so the cases are ticking down, and we're really, pulling on the reins for people to not want to throw their masks away, because our governor just lifted the mask mandate for indoors, which I think is a really big mistake. But we cited the hospital bed availability and all of that. Our vaccination rate is about 70%, but our boosters, especially among the younger population, is not that great. That's been a struggle. And, we just had 2 people in our community pass away from COVID. One was in his 60s and he was healthy, didn't want to be vaccinated. He was like super traditional person that believed in our medicines and all that. And the other person was a employee at our casino who also has vaccination mandate. And they lost a few personnel, but most of the people complied with the mandate. He refused and had underlying health conditions and caught COVID and just recently passed away. So it's been really tragic in that regard. But anyway, we're sticking with our measures until we're sure. So, thank you.
Thank you for that update, Chief Cook, and I'm sad and sorry to hear about the loss of your citizens. That is reflective of my experience. I think most of you know that I work part-time for Cherokee Indian Hospital on the inpatient unit. And the people that we admit with COVID, almost all are unvaccinated. And pretty much all the deaths we've had have been in the unvaccinated population, unfortunately.
Mhm. And we've had Omicron has swept through the tribe, even though we have a vaccine mandate in the tribal government and as well.
And pretty good
and-
vaccination rate as
Huh?
well. And a good vaccination rate as
Right,
well.
and Omicron still swept through. Some
Mhm.
people got barely sick or not sick at all. Some got significant symptoms, but I don't believe anybody, there might have been a couple hospitalizations of elderly, but nobody has passed that was, as far as I know, that was vaccinated. Unless they were really old, but I don't think we have. So I was glad to see the news about the vaccinations and contracting COVID and having a good immune response. That's at least something, reassuring.
Shayla posted in the posted in the comment section that Seneca Nation initiated a 30-day pause on a quarter. A 15-day extension was implemented. 1-4-2-4. We are meeting today to review trends. We meet to review our COVID response at least once weekly. We have ceremonies last and this week. There's also a big football game coming up, so we are watching cases from those gatherings. Yeah. Thank you, Shayla.
And the other note, I just wanted to say too that our traditional people, and because we have midwinter ceremonies coming up, the leadership, chiefs and clan mothers did the essential components of the ceremony in a small group and elected not to have, the longhouses full of people. So that was helpful. So I was glad that they were kind of seeing things the same way that we were. So.
Do we have any other comments or questions about COVID for Dr. Brown or anything for Dr. Brown? He'll take any questions.
Except lottery numbers. I don't have any guidance on the right lottery numbers.
Yeah. So Dr. Brown, I was so disappointed to see them pull region COV2 since we had plenty of that, and we can't even test for a variant down here. I mean, so it's like, that was so disheartening. Then they gave 5,000 doses to the whole state of Alabama of the Sotramab. Come on, so I don't know what the whole country, I don't know how the allocations happened. I don't know any of that, but it's like, you got this, suck it up, do the best you can.
Right. So the decision was made, I can't remember the date, but it's been a couple of weeks. So we basically had 3 different monoclonal antibodies against the COVID virus. 2 of those don't work at all against Omicron. I mean, they're just totally ineffective. The one that is effective is the sotrovimab. It's in very, very short supply. So it's been doled out, I mean, they've given out what they have. They just don't have very much of it. And of course, there were way, way more people that needed it than there was medication. So that one monoclonal antibody is still pretty effective against Omicron. Omicron is now something like 99.9% of the viral samples in the United States are Omicron. So virtually that's the only thing that we're dealing with now. So if somebody tests positive for COVID, you can bet 999 times out of 1,000 it's going to be Omicron, because that's all that we have now, really. So interestingly, Omicron has just completely supplanted, Delta that was very robust. It had completely supplanted all the other viruses. And Omicron within 6 weeks completely took over. So Omicron, maybe, that's why I said I think Omicron's with us for a while. I don't know if we'll get another variant that's, more robust in terms of staying power. And if that's the case, I don't think that's necessarily bad, because like I said, we're stuck with a very contagious but less deadly virus. So that may not be a totally bad thing. Hopefully we'll, the production of the monoclonals will ramp up. We'll have enough as the cases drop, and the supply will meet the demand again. But we're probably weeks away from that at this point.
Sounds great. We are 3 minutes past the hour. If you want to stay on for a minute to ask another question, feel free to. Otherwise, everyone else can go. Have a great day. Thank you. Oh, there is a survey. When you close your window, it'll pop up into your browser. If it doesn't, email me. Thank you all.
Have a great weekend, everybody.
Happy Valentine's Day on Monday.
Yes.